Thank you so much, Dr. Hall, for speaking with me today and our Urban Media Today audience. So I'd like to introduce everyone to Dr. Gregory Hall. He is a primary care physician practicing in Cleveland, Ohio. He's also the author of Patient-Centered Clinical Care for African Americans, and he is an expert in African American health. You also have the dual appointment at Northeast Ohio Medical University.
Yes.
And you've also served on the Ohio Commission for Minority Health, as well as the Cuyahoga County Board of Health.
Yes, I'm currently on the County Board of Health for the second biggest county in Ohio. I no longer serve on the Ohio Commission for Minority Health, and I'm the medical director of University Hospital's Cutler Center for Men. So it's a lot of different things going on, but we're excited. I'm excited to be here, and thanks for having me.
We're definitely excited to have you here as we're thinking of Black History Month. In continuing to create Black history, Black health is obviously a very important and critical piece of our legacy. We've been publishing some studies, and we're seeing a lot of things about the disparities in the outcomes and also diagnosis for African American patients. And we're noticing, even when we're taking into account higher income and private insurance and things like that, we're still seeing worse outcomes. And so I think it's important that we really look at the things that we can do to advocate and spread knowledge for African Americans so that we may have better outcomes, and not to put too much of the burden on the patient, because obviously it is a collaborative process between physicians and the patients, but we're really having worse outcomes, and that's something that obviously needs to be addressed. So just wanting to talk to leading experts such as yourself to talk about these things and what is it that we can do and what information can we share right now as we work to help make more inclusive care, standard of care.
Yeah, and it's a lot, right? The most recent life expectancy data is out, and African Americans are doing poorly. Our men and women combined life expectancy is 75, basically. For African Americans. And so I always make a point of saying, when I was on the Commission for Minority Health, I had to address African American health and Asian American health and Hispanic Latino health. So I bet you and your readers don't know is that the average life expectancy for a white American is 79, right? Wow. The average expectancy for Hispanic Latino is 82. And the average life expectancy for an Asian American is almost 86. So African Americans are doing the worst out of those. Now for Native Americans do worse than African Americans. I always say, there's not a lot of Native Americans in Cleveland or in a lot of urban areas by design, right? But so the problem is not a minority problem. A lot of these health issues are not minority problems. They're African American problems and Native American problems and Alaskan Native problems, right? And so since I'm an African American, it's really about that, right? And so, but those issues are, and they take a focus, they need a focused approach, right? So when my book was being rejected, they said, write about Hispanic Latino health, write about Asian Americans. I don't know anything about that. All I have is African American patients, right? Right. So but the problems are different than usually with other populations. Language barrier here with African Americans is not necessarily a language barrier. It's more of a trust barrier, right? And it's in the cultural issues related to our diet and where are we able to exercise where we live? Are we able to go outside and take a walk? Are we able to, and what is outside? What's in the soil? Is there lead? Is there toxins and whatnot? And so to address the problems that grow out of that, you have to take an African American lens out and address those problems as they grow. I got rejected 8 times. And so when you submit a book, if anyone's ever submitted a book, which I had never submitted a book, it's my first book, right? They say, well, what's the market? So what other books are you competing again that address the same topic, right? Those are the things. So if you want to write a book about, I don't know, Cleveland, what other books are written about Cleveland and how are they doing and how many people read those books, right? So here I am, I'm like, it's a home run. There's 44 million African Americans. We have the worst health outcomes, and there is not a book broadly addressing the health issues in African Americans. And for providers, my book is for doctors and nurse practitioners and physician assistants. So there's no book. So when I took cardiology, there's probably 6 cardiology texts to choose from. But I mean, they all cover the same stuff. It's basically just the authors are different, right?
Mm-hmm.
And so I imagine if when they'd have to say, well, these books exist, and here we have to address it somewhere. There's no other book. Mm. No other book that just looked at African American health. And I thought, this is crazy. I can't believe no one else has done this, as bad as our health outcomes are.
Yeah.
And then every time I got rejected, I was like, I can't believe I'm getting rejected. So I asked the lady, is it my writing? What is it? She's, no, your writing is good. It's just we're used to addressing this as a minority issue, right? And so write about minorities. And I said, African Americans, I wrote back after the first Black Panther, remember the first movie, first Black Panther movie. Mm-hmm. It was the #1 Marvel movie. So on that Monday, right, I'm like, Black things that are almost 100% Black can be popular. You can do this. We just produced it. Almost everybody in that movie was Black. Mm-hmm. Everybody behind the screen. So I wrote an email to a publishing company that had rejected me and said they just didn't feel comfortable doing something that had African American in the name, basically. Mm-hmm. And I said, Black Panther was popular because we got to move past this, not wanting to do something that has Black in the name or African American name, because that sets people off, or just afraid to have that. So call it urban health or call it something else. Mm. Don't call it Black or African American. I say, but that's the part that I'm not negotiating on, because we deserve our own book. Mm-hmm. And I told them they have a book published for a rare cancer that affects 8,000 people a year. They have a book dedicated to a rare cancer that hits 8,000 people a year. 8,000 is nothing. Yeah. You know what I'm saying? Mm-hmm. Right. So I said, if you could publish a book on a cancer that affects only 8,000, I've never seen it in my life. Multiple doctors have never seen it. Why can't you have a book that's dedicated to the health of the people who are spending a lot of insurance money, a lot of tax dollars, a lot of ER dollars? And you couldn't get an answer. You wouldn't. Well, we're just not the right company for you, or whatever it was. But thankfully, the ninth person, I didn't give up. I was watching one biography, and it was Al Jarreau, one of my favorite singers, right? Mm-hmm. And Luther Vandross, and both of them said, how many times we got rejected by record companies. I'm like, you rejected Luther Vandross? Okay. You know what I mean, right? Who was that person? Exactly. Right? Reject. I mean,
someone who's regretful now.
Yeah. Who does that? So I was like, I'm not giving up. I'm gonna keep applying, keep submitting this book to people, because I know it's worthy. And they haven't said it's not my grammar or my writing or anything. They say it's good. So, and mostly got accepted. And so now actually it's been accepted for a second edition. Oh, which I say for authors, that's like your 2-term president. I mean, so I was like, if it got picked up as a second edition, then the book really does have value.
Mm-hmm. It's inherent in the African American tradition that we continue to persevere. So thank you for continuing to fight for that. And I'm so glad, obviously, there's a need for that. And then the second printing is showing that, obviously.
Yeah, and I guess I should say the name. It's Patient-Centered Clinical Care for African Americans. That's the name of it. It's on Amazon. And so welcome to get it if they're interested. But it's for doctors, and they're not really written for the lay person. But I've had my patients buy it and say they've enjoyed it. Just keep track of their own health.
Right, great. Since it is more so for education of medical professionals, do you need to fight to get it into curriculums, or how does that work?
I haven't. It's sort of the publisher's job to do all that. I mean, it's been in the curriculums for some nurse practitioners. Programs, urban ones, as it sort of sits out there. I mean, there's opportunities for people to add them to a medical school curriculum or a residency curriculum. We're going to have a Center for African American Health at University Hospital, and we're going to have tracks in African American health. And so the book will probably be something that people would use in that sort of educational setting. But it's not been, as far as I know, I don't see the demographics really from the publisher that it's been ingrained into any kind of a curriculum at any schools. But it's crazy, but the author wouldn't find that out. I have no idea how the sales are. I know the sales are enough to warrant a second edition. But like anything Black, people that aren't Black aren't overly interested in doing it. And so it's always an uphill battle.
Yeah, that's where we find ourselves in this predicament. You also have a podcast, which is Better Black Health. And I was listening to some of your episodes and calling back to Chadwick Boseman and his unfortunate death at such a young age, which was so impactful to the world because of what a phenomenon that movie was, and also just his acting ability. I understand now that colon cancer screening or colonoscopies are now being recommended at 45 as opposed to 50. But in listening to your podcast, you had said that that had already been in place for African Americans for like 20 years.
20 years.
What would you attribute that to, that for 20 years, more than likely, if we weren't seeing a Black doctor, which sometimes it's just based upon where we live or what's available with our health insurance, that's a whole nother issue. Why was this information not readily known and shared?
It's ignorance and indifference, right? I don't necessarily think anyone was trying to hurt anybody, but you can hurt people with ignorance and indifference, right? And so people just didn't know. And when I used to speak to groups of doctors about African American health, early on, I'd say, "No, raise your hand. Who's read about research or best practices in African Americans? Raise your hand." And I've been at hospitals where 80% of the patients are Black, and no one raises their hand because no one's reading about it. Well, one, because there's no book about it, right? Until mine came out. But there's research, a lot of research you could do, and there's things that you could do, but no one was doing it. And so and someone would say, I have doctors raise a hand again. Why haven't I heard any of this? And what you're talking about, all this data you're throwing at me, how come I'm hearing this for the first time? And I'd always sort of like give a little pause, and I'd say, because Black lives don't matter. I mean, and then everyone look at me, but what other explanation is there, right? There's no other explanation. If it mattered, people would read about it, right? And so what we have to do as a community is and what the Black Lives Matter people did, and just call it out and say, this is what it is. And it's not about us being radical. It's not about us being against the establishment. It's just about us trying to uplift our own health and our own community, just like other communities or racial groups do.
Last August, there was a study that was published by the American Society of Clinical Oncology Journal. And they talked about, there was what it was a cutting edge or best practice therapies that even African Americans who had higher incomes or private insurance were still having a delay in getting this treatment compared to their white counterparts because of insurance authorization. So it's like, you're thinking if you have insurance at all, or even good insurance, that maybe you're not dealing with some of the issues that other people who are underinsured or uninsured have. But then we're seeing that still Blackness tends to be a barrier in the system to getting treatment, to getting timely treatment and the best treatment.
Right. No, it is. And I don't know if you remember this algorithm that came out that the hospitals use to predict when a person should be ready to be discharged out of the hospital. And they were using that and really kind of pushing people out of the hospital because based on this algorithm, which was based on some data that they used that was biased, they were disadvantaging African American patients. And so the data was looking at how many doctor's visits did you have, how many specialty visits did you have, right? And so if you had a low number of doctor visits or a low number of specialist visits, you were perceived as being healthier, right? And so it wasn't looking at number of ER visits, which would have been a better metric. I mean, so it's like you're a person that doesn't have a race. You're just a person, and you haven't seen a primary care doctor in 2 years, and you've never seen a specialist doctor. Therefore, you're healthier. You should be better by day 5. Day 4, and then we're going to start pushing you out. When in reality, they haven't seen those doctors in African Americans. Their blood pressure is high. It's been high for 15 years. They have an aneurysm. It's the exact opposite. They haven't seen a specialist because they can't get off to see a specialist. But I mean, it's not like they haven't been referred by a primary care. So the conclusion that was drawn based on the data, quote unquote data, led to people being pushed out when they weren't ready. So African Americans have the highest readmission rate. When you're a readmit, if you go out and then you have to come back for the same diagnosis days later, we have the highest readmission rate related to that. And so all that, the biased data, not having this is an example. If someone Black in the room had been in the room when they were discussing this algorithm, they said, hello, there's a hole in here. I mean, we could have saved them millions of dollars that are being spent on healthcare, right? And so the same thing is true of, a lot of them don't cover the medications for smoking cessation. Everyone knows that stopping smoking improves your health, lowers your blood pressure, lowers your risk for diabetes and all that. And some of the insurances that don't cover that are disproportionately covering Black lives. Disproportionately Medicaid insurance or work insurances for workers that are first line grocery store workers, lower paying employment tends to have insurances that tend to make those bad decisions as it relates to our lives.
Are you aware of, or are there any incentives for medical professionals to learn more about minority health?
Yeah. Well, so every medical provider has what we call an NPI number, right? And you can look that up online, what's so-and-so's NPI number. And so everything I do, everything I prescribe, every test I order, everything I do as a physician is linked to my NPI number, my death rate, my number of patients, the number of medications I prescribe, just everything, right? And they assigned us that maybe about 10 years ago. And that's true for nurse practitioners and physician assistants, all people that see patients all have NPI numbers. And so there's quality data all attached to my NPI number, right? And so if I'm writing for prescriptions for mammograms, for example, and only half of those get done, and if somebody else is writing for mammograms and hell, 90% of them are getting mammograms, I mean, then that doctor is more effective from again, a data analysis situation than I am in getting women to get mammograms. Now, but here I have a 90+% African American population. So if you're a provider that has a high African American population, you're going to have a lower mammogram, you're going to have a lower colonoscopy rate, lower rectal exam rate. I have patients that look like I insulted them if I say get a colonoscopy. You mean I have nobody stick nothing up my butt? I mean that's going to look like I'm not as good at getting people to do that as, say, a white doctor in a high-end suburb where he has rich patients that want to live, got money. They want to keep their lives the same. Shell, I'll get a colonoscopy. I'll get a mammogram. I'm not dying of nothing preventable. But they know if you have a white provider in that suburb and they're low mammograms, they know something. That person's not effective. That person's not communicating. So the reason I use that exact approach when I say the reason you have to learn about African American health is if you have African American patients, this can help with your outcome. This helps with your data. This helps with all surgeons have what's my mortality rate, morbidity rate, what number of patients of my patients die on the table, or have extra complications. So best practices in treating African Americans, and you have African American patients, it's your advantage to take advantage and learn this information so your outcomes are better because all that data is being tracked about you as a provider. It was a long answer, but that's the answer. So just people don't know that they should be doing that. That's the bigger issue.
You've been practicing for a long time. Are you encouraged at all? Do you feel like things are shifting or changing?
Absolutely. I mean, I see it changing. I see the life of African Americans now have the second highest lung cancer rate, right? It used to be the highest. We had the highest prostate, breast, colon, pancreas. We had the highest rate for all of those. Now we have the second highest rate for lung cancer. We were passed by white people by just edge out a little. So now we're not number one in that. We're number two. But I mean, that's either from smoking cessation, that's from increased screening for lung cancer, increased treatment, just awareness. You're young, but I remember 20 years ago, if I had a party, half the people there were smoking. Now, if I have a party, there's about 3 or 4 people who are going to go outside and smoke. I mean, everybody else is good. The people over 70 that smoke are few and far between. And so in 20 years ago, that was much higher. So through education, through focused care, and through identifying problems, we've seen everything get better. All the rates for all the cancers have gotten better. The rates for heart attacks have gone down. One of the things I say is the reason why there's so much increased Alzheimer's dementia and other dementias is because people are living long enough to get demented. You know, they would normally have had a heart attack from this, or they would have died from diabetes, amputation, blindness, before they got to the point where they would have developed Alzheimer's. So the increase you see in a steadily increase in dementia, age-related things, and we're seeing a decrease in heart attacks, fatal strokes, a lot of the death related to diabetes and so on. So we're solving some problems and then we're causing other problems. I mean, COVID is gonna be in the top 5 of cause of death for the next few years, and that's a whole different conversation. But that's still a different cause of death and injury. There's a lot of people injured by COVID still that are walking around, and we don't know the long-term impact of that even.
That's definitely something we're going to be seeing more of. Not all African Americans can have Black or African doctors. How can we continue to be our own best advocates as we try to increase our healthy outcomes?
Well, I think health literacy is a big problem. Knowing just the minimal amount about your health. And so when patients come in with their medicines and I take their medicines, I'm like, what are you taking? I don't know. I mean, so you should know, if you take medicine every day, you should know what it is, what it does, what it's supposed to do. Just don't blindly just take something that somebody gives you. You wouldn't just blindly eat a plate of food. Somebody hands you a plate of food, unless you starving. Well, what is this? What is it? Is it pork in it? Is it salt? Is it old? Is it new? And you should be the same way really about your medications. What is it? What's it for? What's it supposed to do? And I think when people do that, my patients that are engaged do better. They know why. How does this blood pressure medicine work? What's it supposed to do? Does it affect me having an erection? I don't want any problems there. Does it affect my motivation? Does it make me sleepy? Find out those questions. So if you, in as much as Dr. Google, I call it can scare you to death if you Google something. So I don't know if I'm recommending it, but you should be able to find a doctor that you can ask questions and you can learn. They can learn from you. If you can't find a Black doctor, you can find a doctor of some other race and ethnicity that really wants to help you. And if you're going to be working together and they're able to answer questions and not be annoyed by questions, I think that's who you want, because you want to educate yourself about whatever's wrong with you so you can make the best decisions. And then this should be somebody that you trust enough to listen to and take their advice, right? And so I always use the example, if something goes wrong with the electrical problem in my home, right? I'm not going to go down there and start playing with the electrical box. But I mean, outside of switching it on and off, I'm going to call an electrician. And if whatever electrician I trust, whatever they say, I'm going to decide whether I believe it or not. And I'm going to either get another electrician and ask their opinion, or I'm going to implement whatever they say. Same thing is sort of true. You can't read on the internet enough about medicine to be able to make an independent decision about what to do. You need to find someone who's got that 12 years of experience and history at the least, right? And have them present your problem, then present your preferences. I like this, I like that. I'm too busy to do this. I work nights, so everything's not gonna fit perfectly on every person's life and lifestyle. And then once you find that person and say, here's the way I live, here's what I'm gonna do, here's what I eat, here's what's negotiable, here's what's not negotiable. What's the best treatment plan? And that person should be able to work with you really to find that out. And now that we have virtual visits and the world is really getting smaller because of technology like this. So I think educating yourself and then finding an advocate who specializes in what your problem is, just like an electrician or a plumber. Advocate is specialized in what your problem, or a mechanic, right? You want to find yourself a doctor the same way, rather than trying to become a plumber every time you have a plumbing problem, or become an electrician every time you have an electrical problem, because we know what happens to those people. They usually have bad outcomes at some point.
True. So I have 2 follow-up questions. That one would be, you can just do a Google search, but you may not be led to the most inclusive information. So do you have any particular resources where people should maybe look first? And then the second one being, in looking for a good doctor or advocate, there can be hindrances with insurance and costs and cost prohibitive. So what would you suggest that people think about if they hit those barriers?
Yeah, no, and you're right. I mean, the university hospital I work on is not on one of these insurance panels, like just for 2023. And there's a group of patients that aren't going to be able to see me on their insurance just starting in January of this year. And so and I don't expect anyone to pay cash. You have insurance, you have to find someone who's on your insurance panel. So it's a problem. But I think what we need to do is certainly for health-related African-American information, you can go to my website is drgreghall.com. And I have articles about hypertension and diabetes and some lab differences that are on there, as well as the genetic sequence, multivitamins and whatnot. So that's one resource. We've established a nonprofit called the National Institute for African American Health. It's going to ultimately have a list of doctors across the country that Black doctors that people Google Black doctor, wherever they're, Black doctor near me. I mean, and they'll get African American doctors plus some white doctors whose last name is Black. It's NIA.org is where that a nonprofit is. We're going to put together a panel of doctors across the country. You'll be able to search, but right now it's not on there. But as our lives become more important and tend to matter more, there are going to be more resources online where people can kind of use them. I also saw about a website that had Black doctors you could see through virtual visits that don't necessarily have to be in your city or whatever. And so that's a resource out there as well.
Well, this has been very enlightening. Thank you so much for all the information you provided. Is there anything else that we haven't touched upon that you feel is really important to better health outcomes for African Americans?
Yes. I don't know what they are. I guarantee you there is. But I know I appreciate it. We're putting out Better Black Health with Dr. Greg Hall is out there, and so we're doing. I've been asked to do a couple more that I'm going to try to do next weekend. There's resources. Certainly, Urban Media Today. It's a great resource to go to and find out what people are talking about. Doing your research. But you need to have a primary care doctor. Get a primary care doctor you can trust, that you can use, that you can work with, and that's a person who knows you the best, who can give you the sort of the best advice for your particular situation. But there's just all sorts of information. I learned a lot. I interviewed a young lady who had ovarian cancer and then had breast cancer, and she was talking about the value of chemotherapy and being in cancer trials and how you get better care. People in cancer trials get better care than people that aren't in cancer trials. And we Black people tend to avoid experimentation, right? But like, man, she's like, you don't know. It's not like a Tuskegee. These people they get paid, they get best care, they get this, they get monitored more closely. So there's just a lot out here than what our preferences or what way my father looked at life. Don't like doctors, don't like medicine, don't like hospitals. That's not an approach to a long life, right? So, doctors have done some bad things, but we're really trying to rectify things now to try to improve everyone's health.
Thank you for saying that about clinical trials. Actually, I'll be speaking with another doctor who does work in diversity and inclusion in putting together a study. So we're excited to learn about that as well. I think a lot of African Americans are aware of our earned reticence to a lot of medical treatment and possibly experimentation, things like that. Obviously, we want to live long and pass on good health and good health practices to our descendants and our family. But I think in a lot of ways, the onus is on the medical community that hasn't really,
That's exactly true. And I have a whole nother talk on that. Yeah, that talks about Tuskegee and the experimentations on slave girls, unnecessary doing pelvic surgeries on them and grave robbing. There's a long, horrid list of what medicine has done to the Black community. So that's why the trust isn't there. But we're now trying to regain that trust, and so it's just one of those things that you don't have to, but just be open to try to give that trust back. But I get for why it's gone. There's no question. And half of African Americans don't trust doctors and hospitals. And I wonder why the half that do trust them. I mean, there's more evidence to not trust us than there is to trust us. But trust is then regained one person at a time, and then over a period of time too, not just a one-off. But thanks so much for having me on. I appreciate you. This has been a great interview.
Yes, thank you so much. We appreciate you as well. This has been wonderful information. We're so happy to have created this connection with you and what you've really done to help African Americans and health outcomes.
Thanks so much.